Good day, dear students. Please register in chart for lecture. Do you hear me? Please register in chat. So today our lecture is devoted to the cranial nerves. And on today's lecture we will discuss following issues like a scheme of description of cranial nerves, development in ontogenesis of cranial nerves, various classifications, sites of exit and or entrance of cranial nerves at the base of the brain and base of skull, location of nuclei of cranial nerves, how various components of cranial nerves are formed, and briefly we will describe each cranial nerve with the main branches as well as zones of innervation and some clinical issues. And finally, we will discuss parasympathetic ganglions, which are related to particular cranial nerves. So, as you know, there are 12 pairs of cranial nerves, and one professor, Marty Hyken, proposed these mnemonics for easy memorizing of cranial nerves. He proposed next sentence. Old Opie occasionally tries trigonometry and feels very gloomy, vague, and hypoactive. As you can see, first letters in each word corresponds to first letter, indicates particular cranial nerve. Now we will discuss some classification of cranial nerves. First one based on development of cranial nerves. Due to this classification, all cranial nerves can be subdivided into 4 big groups. First one, nerve arising from the brain, which are quite specific nerves. They are first and second pairs, olfactory nerves and optic nerves. Actually, they are not really nerves. They, due to development, they are outgrowths of brain. Second group of nerve derives from cephalic myotomes, and these nerves provide innervation to muscles of eyeball. They are oculomotor, trochlear, and abducens nerve. Next, nerves of visceral arches. They are trigeminal, facial, vestibulocochlear, glossopharyngeal, vagus, and accessory nerve. And last group, which includes only one nerve, it is nerve developed by union of spinal nerves. It is 12th cranial nerve. Next, formation of nerve components. I think you understand that cranial nerves might have 3 basic components: sensory, motor, and parasympathetic. And this picture shows formation of each of these components. First one, sensory component. As you know, there are two types of sensory cells due to structure. They are bipolar or pseudo-unipolar neuron and cell bodies of these neurons located in the sensory ganglion. In our case, in ganglions of cranial nerves. And as you can see, this ganglion contains cell body of pseudo-unipolar neuron. It has a single process just after origin splitting into two. Peripheral one goes to skin, where it terminates as receptors, and central one goes via trunk of cranial nerves towards its sensory nuclei placed in brainstem. Motor component. As you know, some cranial nerves have motor nuclei located in the brainstem. This nuclei contains multipolar neurons and especially its cell body. And axons of these neurons pass through corresponding cranial nerve towards skeletal muscle. And last component, parasympathetic. As you know, efferent part of vegetative reflex arch has one interruption occurring in ganglion. So, and due to relation with ganglion, there are two types of fibers, preganglionic and postganglionic fibers. Preganglionic fibers actually are axons of neurons located in parasympathetic nuclei of the brainstem, and postganglionic fibers are axons of neurons located in parasympathetic ganglion. And these postganglionic fibers travel to glandular epithelium. And due to the presence of different types of fibers, we can subdivide all cranial nerves into three groups. First one, sensory or afferent. Actually, they are nerves of special sense. They are olfactory nerve, optic nerve, and vestibular-cochlear nerve. Second group, motor or efferent. Oculomotor nerve, trochlear nerve, abducens, accessory, and hypoglossal nerve. Let me pay your attention to oculomotor nerve. In some textbooks it is described as mixed nerves due to the presence of motor and parasympathetic fibers. Actually, nature of these two fibers is same. They are efferent. They send impulse from center to effector. So due to this issue, we consider oculomotor nerve as definitely motor or efferent, but not mixed. And last group, mixed nerves, those ones having two components, sensory and motor or efferent. And this group involves trigeminal nerve, facial, glossopharyngeal, and vagus nerve. How to memorize easier function, sensory, motor, or mixed? These mnemonics, as for me, helps you to memorize. There is a sentence, some say marry money, but my brother says it's bad business to marry money. First letter S in words indicates sensory, letter M motor, B both. So some, first cranial nerve number one, sensory, say, second sensory, marry, third one motor, money, fourth one motor, but fifth cranial nerve both sensory and motor, so it is mixed. Next, M, sixth motor, and so on. Besides that, there is one more classification of cranial nerves due to their origin and topography. All cranial nerves can be divided into false and true. I explained this above. It is because first and second cranial nerves are not real nerves. They are like derivatives of brain, respectively telencephalon or diencephalon. But other nerves really, due to their structure and development, true nerves from 3rd to 12th cranial nerves. And these true cranial nerves, due to their topography and function, can be conditionally subdivided into three groups: oculomotor nerves, which provides innervation of skeletal muscles of eyeball. They are third, fourth, and sixth pairs. Nerves of pontocerebellar angle, that are fifth, seventh, and eighth, because these nerves enters or exit brain in area of pontocerebellar angle. And last group, caudal cranial nerves, because they exit brain most caudally from medulla oblongata. They are 9, 10, 11, 12, and partly in spinal cord. Now let's revise a site of exit of cranial nerves at the base of brain. First cranial nerve, as you know, it enters brain in olfactory bulb, which is followed by olfactory tract. Second cranial nerve, optic nerve, it enters brain in optic chiasma, which is a part of diencephalon. Third cranial nerve, or oculomotor nerve, its root is found at the medial surface of cerebral peduncle in sulcus oculomotorius, or also we can describe this place as interpeduncular fossa. It is in between right and left cerebral peduncle, interpeduncular or Tarens fossa. Fourth cranial nerve, trochlear, it is very strange. This nerve exits brainstem at the dorsal side, and after that it loops laterally to cerebral peduncle and appears on the ventral surface. Fifth cranial nerve, trigeminal nerve, it has two roots, sensory and motor, and this nerve exits brain at the place where pons becomes middle cerebellar peduncle. Sixth cranial nerve, or abducens nerve, its root exits brainstem between the posterior side of pons and pyramid of medulla oblongata. This groove is known pontobulbar groove. Then, seventh and eighth cranial nerve, they exit brainstem in pontocerebellar angle. Then, 9, 10, and 11 cranial nerves exit brain behind olives, groove behind olives, and they are placed from top to bottom, 9, 10, 11. And 12 cranial nerve, hypoglossal, it exits in groove between pyramid and olive. Besides that, you have to know sites of exit or entering of cranial nerves at the cranial base, and also we will mention from 1st to 12. First cranial nerve, olfactory nerve, enters skull through openings in cribriform plate of ethmoid bone. Then second cranial nerve, optic nerve, enters via optic canal. Then third cranial nerve, oculomotor, exits skull through superior orbital fissure. Fourth one, trochlear also. As for the fifth cranial nerve, as you know, it has three branches: ophthalmic, maxillary, and mandibular nerves. Ophthalmic nerves enters skull through superior orbital fissure, then nervus maxillaris through foramen rotundum, and nervus mandibularis through foramen ovale. Sixth cranial nerve, abducens nerve, exits through superior orbital fissure. Then seventh cranial nerve, it has very complicated course. Actually, it moves via fascial canal. This canal begins at the bottom of internal acoustic meatus and terminates in stylomastoid foramen. Eighth cranial nerve passes through internal acoustic meatus. Then 9, 10, 11 cranial nerves pass through jugular foramen, and hypoglossal nerve passes through hypoglossal canal. Let's revise nuclei of cranial nerves. As you know, first and second cranial nerves are false, so they have no nuclei. Third cranial nerve have nuclei in the midbrain, especially in the cerebral peduncle, and third cranial nerve has two nuclei, nucleus motorius nervi oculomotorii, found at the level of superior colliculus, and one parasympathetic nucleus called accessory nucleus of the oculomotor nerve. You have to know they two eponyms. First one accepted in our country, Yakubovich nucleus, and in Western Europe and America it is known as Edinger-Westphal nucleus. Then fourth cranial nerve, trochlear, has one motor nucleus found in tegmentum of cerebral peduncle, but on the level of inferior colliculus. Then fifth cranial nerve, it has two nuclei, motor and sensory. Motor one found in pons and projects to upper trigone of rhomboid fossa in fovea cranialis. And sensory nucleus is quite strange. It has three parts. It is very long nucleus. It starts from the midbrain and it moves through pons, medulla oblongata, and terminates at the upper cervical segments of spinal cord. So, due to topography, we can distinguish three parts in this nuclei. Mesencephalic nucleus within midbrain, pontine or principal nucleus in pons, and remaining part is spinal nucleus. Next, sixth cranial nerve, abducens. It has one motor nucleus, nucleus motorius nervi abducentis. It projects to upper part of facial colliculus in median eminence. Then seventh cranial nerve, it has three nuclei, motor, sensory, and parasympathetic nucleus. Facial nucleus motorius nervi facialis projects to facial colliculus. Then sensory nucleus known as nucleus tractus solitarii. It is common for three cranial nerves, 7, 9, and 10. And one parasympathetic nucleus called nucleus salivatorius superior. It projects laterally to median eminence in rhomboid fossa. Eighth cranial nerve, vestibulocochlear, has two parts, vestibular and cochlear part, and there are four vestibular nuclei. Due to topography, they are known as superior, inferior, medial, and lateral. Eponyms, you know them, Bechterew, Schwalbe, Roller, and Daters. And cochlear part has two nuclei, dorsal and ventral cochlear nuclei. Ninth cranial nerve, it has also three nuclei. Motor one, known as nucleus ambiguus, it is placed on, it projects between trigonum nervi hypoglossii and trigonum nervi vagi. Sensory nucleus, nucleus tractus solitarii, and inferior salivatory nucleus. 10th cranial nerve has two common nuclei with ninth one and one specific parasympathetic nucleus called nucleus dorsalis nervi vagi. 11th cranial nerve, nervus accessorius, has two motor nuclei. First one is common with 9th and 10th cranial nerves, nucleus ambiguus, and another one, nucleus spinalis nervi accessorii. And 12th cranial nerve, hypoglossal nerve, has one motor nucleus projecting into trigonum nervi hypoglossii in lower trigone of rhomboid fossa. You have to know scheme, how to plan, how to describe true cranial nerves. First one, you have to mention its number and name. in English and Latin. Second, functional characteristic. It means sensory, motor or mixed. Third one, source of development. You have to use classification based on origin of cranial nerves and mention group. Either nerves deriving from cephalic myotomes, derivatives of visceral arches, or formed by union of spinal nerves. Fourth one, nuclei of nerve. You have to mention their name, functional characteristic, which means it is motor, sensory or parasympathetic, and topography. Topography means location, which part of brain, cerebral peduncle, pons or medulla oblongata, and projection to rhomboid fossa. Don't confuse, please. Location of nucleus and projection to rhomboid fossa. Then, principle of nerve formation. How I mentioned above, you have to say if nerve has sensory component, you have to mention what it is formed by. If motor component, axons of which nucleus. If parasympathetic fibers, axons of which nucleus. Next, you should describe sites of entry or exit from brain, then from skull. After that, you should describe pathway of nerve on periphery, related parasympathetic ganglions if they are present, of course, and after that main branches of nerves and regions of their innervation. And finally, after completing of all cranial nerves, you should be able to explain innervation of organs and tissues, like sensory innervation, motor innervation, or parasympathetic innervation. And let's briefly go through all cranial nerves. First pair of cranial nerves, olfactory nerve or nervus olfactorius. We said that it is false cranial nerves. Due to development, it is derivative of brain, especially telencephalon. And actually, olfactory nerve is a part of conducting tracts of olfactory analyzer. In this case, you have to start to describe in details topography, pathway of smell analyzer. As you know, first neurons are located in the nasal mucosa lining superior nasal concha and superior nasal meatus. Here, sensory neurons have peripheral processes forming receptors, central processes form many phyla olfactoria, together known as olfactory nerves. And these nerves penetrate cribriform plate of ethmoid bone and enters olfactory bulb, where the synapse and second neuron of olfactory conducting tract located. Axons of second neuron travel through olfactory tract, and these axons terminate in three places where third neurons are located. First one is olfactory trigone, second one anterior perforated substance, and third one is septum pellucidum. And finally, cortical end of olfactory analyzer is located in olfactory area uncus and parahypocampal gyres. And in case of damage to olfactory nerves, anosmia appears. Second pair of cranial nerves, optic nerve. It is also false cranial nerve because it is actually outgrowth of brain. Due to development, it derives from diencephalon, and it is a part of conducting tracts of visual analyzer. And let's briefly revise it. So, actually, first neuron of this analyzer lies in the retina. It is represented as three links. Then, optic nerve enters cranial cavity through optic canal, and medial fibers of optic nerves, it means fibers from medial parts of retina, decussate, and this place of decussation known as optic chiasma. And be attentive that only medial fibers decussate, lateral fibers do not decussate and follow from own side. After that, optic chiasma is followed by optic tract, and as you can see, optic tract has two types of fibers, lateral ones from own side and medial ones from opposite side. Then optic tract sends its fibers to three subcortical visual centers. One of them is mentioned on this picture. It is basic one, lateral geniculate body with corresponding nucleus. Besides that, pulvinar is subcortical visual center. It has relations to extrapyramidal system and limbic system. And third one is superior colliculus with nuclei of superior colliculi. It has links with third cranial nerves for pupil light reflex. And from main subcortical center, which is lateral geniculate body, axons form optic radiation. It is known also as Graciole radiation, and it terminates in visual cortex, which is found in occipital lobe on either side of sulcus calcareus. And I would like to give you some clinical issues related to conducting tracts of visual analyzer. Look, let's consider case number 1. In case of damage to one optic nerve, let it be left optic nerve, as you can see, this nerve has blue line and red line from corresponding half of retina. And you have to know that image is formed vice versa on the retina, so medial half of retina gets information from temporal visual field, and lateral half of retina responds for nasal visual field. So in case of damage to left optic nerve, right eye is not disturbed at all, but left eye can't see at all. As you can see at this chart, left one blindness, right one, everything is okay. And unilateral blindness is known as amaurosis. Then partial loss of visual field known as scotoma, when some fibers of optic nerve, for example, are damaged. That is second case. You see only external or lateral fibers are damaged, and in this case you see only nasal visual field of the left eye is lost. Next, case number 3, damage to central part of optic chiasma. Remember, we said that central part contains decussated fibers, but external parts undecussated fibers. And actually, damage to central part of optic chiasma is very common problem in case of benign tumor of hypophysis cerebri called adenoma. As you know, any tumor is like a swelling, enlargement of tissue, and enlarged hypophysis compresses central part of optic chiasma. And in this case, you see what visual fields will be lost. Look, blue line follows from medial half of retina of right eye, and this half controls temporal visual field at the right side. And another line is a red one. It goes from medial half of left retina. It also controls temporal visual field. So as you can see, case number 3, both temporal visual fields are lost. In this case, when half of visual fields is lost, we are saying hemianopsia, loss of half of visual fields. In this case, because both temporal visual fields are lost, we are saying bitemporal hemianopsia. And case number 4, damage to optic tract. For example, left optic tract, you see it is definitely blue and it gets its fibers, uncrossed fibers from own side. You see they came from lateral half of retina responding for nasal visual field. And another blue line came from medial half of contralateral retina controlling temporal visual field at the right side. So, in case of damage to left optic tract, right visual fields will be lost. In left eye it is nasal visual field, in right eye it is temporal visual field. And, for example, if left optic radiation or left visual cortex is damaged, absolutely same situation. Also hemianopsia, loss of half of visual fields takes place. Next cranial nerve, oculomotor. As you remember, it has it is motor nerve because it has one motor nucleus and one parasympathetic nucleus. Due to origin, it is nerve of cephalic myotome. Nuclei, we said, they are motor and parasympathetic. They are found in tegmentum of cerebral peduncle at the level of superior colliculus. Then, oculomotor nerve exits brainstem on the medial side of cerebral peduncle. After that, it travels through sinus cavernosus together with many nerves and internal carotid artery. Then exits skull through superior orbital fissure and divides into superior and inferior branches. In general, this nerve supplies to most of muscles of eyeball, such as levator palpebrae superioris muscles, inferior oblique muscle, and 3 rectus muscles except for lateral one. But they are motor component. As you know, oculomotor nerve has also parasympathetic fibers, and these fibers also supply to muscles of eyeball, but smooth muscles, which are sphincter pupillae muscle and musculus ciliaris. In case of damage to oculomotor nerve, there are some signs appear. First one, called ptosis or drooping of eyelid. It is due to lack of innervation of levator palpebrae superioris muscle. Then, strabismus or lateral squint. It is due to problems with innervation of rectus muscles. And strabismus, if it is unilateral lesion, it leads to diplopia or double vision because in such case, patient can't focus both eyes at one object. It results in diplopia. Then, besides that, of course, movements of eyeball will be disturbed, and due to the presence of parasympathetic component, as we said, it supplies to musculus sphincter pupillae and ciliaris. Lesion to parasympathetic component will cause dilation of pupil called mydriasis, and if it is unilateral lesion, it leads to anisacaria, unequal pupils. At the unaffected size it will be normal, but at the affected size it will be dilated due to mydriasis. And because oculomotor nerve supplies to ciliaris muscle, which respond for accommodation, loss of accommodation may develop as well in case of damage to oculomotor nerve. trochlear nerve. This nerve is unique due to some issues, and I posted these unique features on this slide. First of all, only trochlear nerve exits brain not on ventral surface but on dorsal. It exits on either side of frenulum of superior medullary velum, and after that it travels laterally to cerebral peduncle, and only after that it appears on ventral surface of the brain. Next feature that motor neurons, fibers of motor neurons just after origin decassate. Next, trochlear nerve has longest intracranial course, and it is thinnest cranial nerve, so it contains less number of fibers. Trochlear nerve lesion, actually isolated lesion happens very rarely, and lesion actually causes diplopia because one eye at the affected side rotated abnormally. Patient can't focus the sight on object and result in diplopia. Next nerve from oculomotor group, nervus abducens. It is motor nerve. It has one nucleus located in pons, nucleus motorius nervi abducentis. Fibers go through cavernosus sinus, then through superior orbital fissure it enters orbit and supplies to lateral rectus muscle. Lesion to abducens nerve causes similar signs as trochlear nerve and oculomotor nerve: strabismus, diplopia, and disturbances of movements of eyeball. Trigeminal nerve, nervus trigeminus. It is mixed nerve. It derives from visceral arches, has two nuclei, motor and sensory. Sensory one has three parts: mesencephalic, pontine, and spinal part, and that is true cranial nerve. So if it has sensory component, it should have sensory ganglion. And really, trigeminal nerve has trigeminal ganglion or Gasserian ganglion. It is formed by pseudo-unipolar neurons, and its central processes form major trunk of trigeminal nerve, but peripheral processes forms three branches of trigeminal nerve. First one, nervus ophthalmicus; second, nervus maxillaris; third one, nervus mandibularis. Besides that, nervus mandibularis has also motor component. And if to generally describe zones of innervation for each nerve, details we will study on practical classes, branches of these basic divisions, but now generally, olfactory nerve, it is sensory, so it supplies to dura mater of the brain. Actually, before to enter cranial cavity, exit cranial cavity, branches of trigeminal nerve gives rise to meningeal branch supplying to meninges of brain, especially dura mater. Then, secondly, olfactory nerve supplies to tissues of orbit, eyeball, surrounding tissues, lacrimal gland, and so on. Then nasal mucosa due to the presence of anterior and posterior ethmoidal nerves, and it supplies to skin above palpebral fissure and at the back of nose. Maxillary nerve supplies to meninges of brain, as we said above. After that, upper teeth, nasal and oral mucosa, and skin between palpebral fissure and oral fissure, so middle part of the face. Mandibular nerve, it has two components, sensory and motor. Sensory one supplies to meninges of brain, lower teeth and gums, mucosa and floor of mouth. Then general sensory innervation of anterior 2/3 of tongue and skin below to oral fissure and skin of temporal area. Motor fibers supply to all muscles of mastication, and besides that some suprahyoid muscles. They are musculus mylohyoideus and anterior belly of digastric muscle. Damage to trigeminal nerve causes loss of all types of sensation within innervated zones. It means general sensation, not special. Then loss of related with trigeminal nerve reflexes and palsy of muscles of mastication. Sensory fibers, in this case, labyrinth apply small amounts of any solution to tongue, and patient should say what is he or she feeling. Lesion of facial nerve known as Bell's palsy. It is manifested as paralysis of muscles of facial expression, facial drooping, then salivary drooling. It is due to paralysis of mimic muscles, and also disturbances in lacrimation. First of all, tearing. It is because of lack of tonus of lacrimal part of orbicularis oculi muscle, and also secretion of lacrimal fluid will be disturbed due to the presence of greater petrosal nerve, providing parasympathetic innervation to this gland. Vestibular cochlear nerve. It is sensory nerve. It provides special sense, hearing, equilibrium and balance. It has two parts, vestibular and cochlear. Cochlear part responds for hearing, vestibular part for equilibrium and balance. Ninth cranial nerve, glossopharyngeal nerve. It is mixed nerve. It has three nuclei, motor, sensory and parasympathetic, and this nerve provides following innervation. Motor fibers supply to stylopharyngeus muscle. Sensory fibers, it has two types, spatial and general. Spatial sense for posterior 1/3 of tongue, and general sense it is for posterior 1/3 of tongue, pharynx, palatine tonsils, eustachian tube, tympanic cavity, and very specific sensation from sinus and glomus caroticus. And parasympathetic fibers supply to parotid gland. Lesion to branches of glossopharyngeal nerve causes ageusia, loss of taste, but it is partial loss of taste because taste sensation is provided by three nerves: facial nerve, glossopharyngeal, and vagus nerve. Insignificant disturbance of swallowing. Insignificance, it is because only one muscle involved in swallowing is innervated by glossopharyngeal nerve, stylopharyngeus, but remaining ones supplied by vagus nerve. Vagus nerve. It is favorite students' nerve because it supplies most of inner organs in our body. It has three components: motor, sensory, and parasympathetic. Motor components supply to muscles of pharynx and larynx, so they respond for swallowing and voice production. Then sensory, general sense from skin at the back of ear, external acoustic meatus, part of tympanic membrane, larynx, trachea, esophagus, thoracic and abdominal viscera, up to the sigmoid colon. Besides that, vagus nerve conducts information from baroreceptors and chemoreceptors. Special sensory taste buds also found besides tongue at the epiglottis and pharynx, so it is provided by vagus nerve, and parasympathetic innervation by vagus nerve provided to smooth muscles of abdominal organs, visceral gland secretions, relaxation of airways, and so on. So, damage to vagus nerve causes hoarseness or loss of voice, impaired swallowing, dysfunction of gastrointestinal tract, blood pressure anomalies, and in case of bilateral damage, it causes death. Accessory nerve. It has two motor nuclei. One of them is common with 9th and 10th cranial nerve, nucleus ambiguous, and another one spinal nucleus. And actually this nerve, after exiting through foramen nucleare, divides into external and internal branches. Internal one joins and innervates muscles of pharynx and larynx. External branch goes to musculus sternocleidomastoideus and musculus trapezius. And this picture shows how to test function of accessory nerve, especially muscle of sternocleidomastoid muscle and trapezius muscle. Here you can see testing of sternocleidomastoid muscle, how to detect tone of muscle. An injury to accessory nerve causes head to turn towards injury site as a result of sternocleidomastoid muscle paralysis, shrugging of the shoulder become difficult. Hypoglossal nerve, nervus hypoglossum, it is formed by union of spinal nerves. It has one motor nucleus, nucleus motorius nervi hypoglossi, and it exits cranial cavity through hypoglossal canal. Then it gives off branches to all intrinsic and extrinsic muscles of the tongue, and gives off one branch which joins cervical plexus to form ansa cervicalis to supply infrahyoid muscles. And one more thing related to topography of hypoglossal nerve. Here you can see hypoglossal nerve, and I hope you remember that hypoglossal nerve bounds superiorly, so-called Pirogov's triangle, which transmits arteria lingualis. And how to test function of hypoglossal nerve? Patient is instructed to stick out the tongue and then move it laterally against resistance. Lesion to hypoglossal nerve causes paralysis, and in this case tongue deviates towards paralyzed side in case of protrusion. And finally, we will talk about parasympathetic ganglions related to the cranial nerves. When you studied vegetative nerve system, we did not concentrate mainly attention on these ganglions because they related to cranial nerves. At that time, you were not aware about details of cranial nerves. And here I am giving you four pictures as for me useful to understand these ganglions. How to describe this picture? Actually, according to each ganglion, you have to say some things. First of all, topography, then how this ganglion receives fibers, and how fibers move after ganglion and what they are supplied to. First one, ciliary ganglion, which is found in tissue of orbit. As you can see, this ganglion is parasympathetic because parasympathetic fibers interrupt in it. But macroscopically, this ganglion is fused with sensory nerves from trigeminal nerve, and postganglionic sympathetic fibers pass through ganglion. So, ciliary ganglion, it gets sensory component from nervus nasociliaris, which is branch of nervus ophthalmicus, which is first division of trigeminal nerve. Then, this ganglion receives preganglionic parasympathetic fibers. They originate from Yakubovich nucleus or Edinger-Westphal nucleus, or anatomically it is known as nucleus motorius nervi oculomotorii. Then preganglionic fibers move through oculomotor nerve and its branches and interrupts in ciliary ganglion. Third fibers received by ciliary ganglion are postganglionic sympathetic. But we have to describe them starting from center. As you remember, nucleus intermedio lateralis, especially last uppest segment C8, TH1, TH2. Then axons of these neurons travel through anterior root of spinal nerve, then wide communicating branch. They reach ganglions of own level, no synapse here, ascends through interganglionic rami and synapse in superior cervical ganglion. After that, postganglionic fibers from this ganglion form plexus around internal carotid artery. After that, plexus around ophthalmic artery, and without any interruption they go through ciliary ganglion. After that, this ganglion gives off short ciliary nerves which carry three components: sensory, parasympathetic and sympathetic. Sensory component provide innervation to eyeball, parasympathetic component to musculus sphincter pupillae and musculus ciliaris, while sympathetic component supplies to musculus dilatator pupillae. Next ganglion, ganglion pterygopalatinum, located in pterygopalatine fossa. As you can see, this picture resembles previous one because this ganglion also receives three types of fibers. First one, sensory. It gets branches from nervus maxillaris. Then preganglionic fibers. Parasympathetic starts from nucleus salivatorius superior. Axons move firstly through nervus facialis, then nervus petrosus major, then this nerve joins nervus petrosus profundus to form Vidian nerve, nervus canalis pterygoidei, and parasympathetic fibers synapse in this ganglion. Sympathetic fibers come from nucleus intermedio lateralis uppest possible segments, then preganglionic fibers move through anterior root of spinal nerve, wide communicating branch, no synapse in ganglions of own level, interganglionic rami towards superior cervical ganglion and synapse here. Postganglionic fibers from this ganglion form plexus around internal carotid artery. After that it gives off nervus petrosus profundus. It joins nervus petrosus major to form nervus canalis pterygoideus, and it reaches pterygopalatine ganglion. And if to say generally, this ganglion supply to lacrimal gland and also glands of nasal and oral mucosa. Submandibular or sublingual ganglion, it depends on gland. If we talk about submandibular gland, we mention submandibular ganglion. If sublingual gland, sublingual ganglion. Same as previously. This ganglia gets three types of fibers. First one, sensory, coming from nervus mandibularis and its branch nervus lingualis. Then preganglionic parasympathetic fibers start in nucleus salivatorius superior. Then they travel through facial nerve and its branch chorda tympani. Sympathetic fibers traditionally originate from nucleus intermedio lateralis, reach superior cervical ganglion, and postganglionic fibers form plexus around external carotid artery. After that, plexus around either facial or lingual artery. Again, it depends on gland. If we talk about submandibular ganglion and gland, we mention arteria facialis. In case of sublingual or sublingual ganglion with sublingual gland, we have to mention arteria lingualis. And fibers arising from this ganglia supply to respective gland. And last, parasympathetic ganglion, ganglion oticum or otic ganglion. It is located close to parotid gland. Also it gets three types of fibers. Sensory ones come from nervus mandibularis, especially its branch nervus auriculotemporalis. Preganglionic parasympathetic fibers arise from nucleus salivatorius inferior, which is nucleus of 9 cranial nerve. After that they travel via nervus glossopharyngeus, then nervus tympanicus, and its continuation nervus petrosus minor. And postganglionic sympathetic fibers traditionally arise from ganglion cervicalis superior, form plexus around external carotid artery, and after that around artery supplying to parotid gland. It is arteria temporalis superficialis, which is one of the terminal branches of external carotid artery. And postganglionic fibers from otic ganglion supply to parotid gland. Thank you for your attention.